please.
Good morning, everyone. It is an honor for me to introduce Dr. Shelly Timmons this morning. Dr. Timmons earned her Bachelor of Science in Biology and Arts in Rhetoric at the University of Illinois, and also earned her medical degree from the University of Illinois College of Medicine in 1991. She completed her internship and residency training at the University of Tennessee Health Science Center in 1997, and also earned her PhD in anatomy and neurobiology there as well in 2002. She began her career as neurosurgeon in 2097 at Sims Murphy Clinic, and then she has been a leader at neurosurgical care in Memphis. She was associate professor and chief of neurotrauma division at University of Tennessee, as well as assistant dean for graduate medical education. She was vice chair of administrative in the Department of Neurosurgery and director of trauma at Penn. She previously served as director of neurotrauma and residency program, director at Geisinger Health System. She serves as journal editor of different journals. For example, World Neurosurgery for the neurotrauma section. She became chair of the Department of Neurological Surgery at Indiana in 2019 to date. And we also can see many honors and awards. The next one. Oh, I think something, Dr. Q got disconnected.
I apologize, my signal completely died. I'm gonna finish this and then, I know that you were going through this and I want to show the next slides, Go ahead, sorry, Andrea.
And we can also see here her impact on the literature over the years. And we are very, very honored to have you here today, Dr. Timmons.
And I wanted to show, these are the plaques that our team puts together for you, Shelly. So welcome, thank you. The idea of these lectures is to incite collaborative efforts and to get people to think. We don't look for all the answers, but we like to hear about what you're doing, your work and your career. And this is actually the Andres and the team put this together. They put all these plaques and they'll send it. If they didn't send them to you already, they'll be in your office in the next few days. So without any further, I thank you. Thank you very much for doing this and for being here, with us. And we're excited to have you. So take it away, please, Dr. Timmons.
Well, thank you so much, Q and Andrea, for that nice introduction. I'm really excited to be here this morning with you all, and hopefully I can be down there sometime for a visit and tour your wonderful facilities there. I'm just going to pull up my talk here and just let me know if you have any difficulty with the audio. I just want to make sure that you can hear everything okay. Let me get to this.
You sound great. So that's okay. Perfect right now.
Terrific.
And we're beginning to see your screen. Let's see if it comes up.
I've got to put in a password here for some reason, but let me see if I can.
There you go. We see your screen right now.
Terrific. Okay. I will start slideshow here. Thank you so much for the kind invitation to share some thoughts with you today on the state of TBI care. I am honored to be invited to give this lecture, named for the generous benefactors of the Mayo Clinic, Florida Neurological Surgery Residency Training Program. It is important for the legacy of all three of these individuals and is an apt recognition for excellent care. I'd like to focus today on the state of long-term TBI care in the United States, and I will touch on a recent report of the National Academies of Sciences, Engineering, and Medicine. This body has recently convened a TBI forum to address multiple issues raised in this report in the coming decade. By way of disclosure, I am representing the AANS as a volunteer expert in the activities of the forum. We began our deliberations just 2 weeks ago, and I'm very heartened by the caliber of people involved and the degree of seriousness with which the group has accepted its charge to change the face of TBI diagnosis, intervention, and awareness. I will also review some of the sequelae of TBI that may make long-term management challenging and can impact on ultimate functional outcomes. We are fortunate to have Don Berwick as the chair of the TBI Forum. For the residence history lesson, he was a key architect of the modern quality and patient safety efforts in the U.S., having served as a leader in the Institute for Healthcare Improvement and key author on the seminal Institute of Medicine/National Academy's publication entitled To Err is Human, Building a Safer Health System in 1999. This publication served as a roadmap for patient safety initiatives in our country. We likewise hope that our work on the TBI Forum will pave the way for seminal and necessary changes in the manner in which TBI care is approached. So why focus so much effort on TBI at this juncture? As many as 55.9 million people globally are estimated to experience a mild TBI as defined by GCS. 5.48 million further experience a severe TBI. More than 55 million people are thought to be living with the effects of a medically treated TBI worldwide. In the United States alone, 4.8 million people are evaluated and treated in the ED for a TBI annually. This accounts for about 2% of total emergency department visits, hospitalizations, and deaths. Only 13 to 25% of patients receive rehabilitation in an inpatient setting of those suffering from moderate, severe, or penetrating TBI. Disparities in care are very common, with rural, racial, and ethnic differences in access to care and outcomes. About 2.5 million caregivers are supporting a person with a TBI in the U.S. alone. What happened to the sound?
We were hearing it very well, Shelly. I'm not quite sure. It seems like it stopped somewhere around there. As you fixing that, those numbers are amazingly large and concerning.
As many of you know, I am typically much more likely to lecture on acute care multimodality treatments of severe TBI in the ICU, or the nuances of decompressive craniotomy surgical technique for intracranial hypertension. However, over the years, I have seen that one of the largest care gaps affecting outcomes occurs when the patient leaves the hospital, and this national effort to address these problems is a critical step in augmenting what we do as neurosurgeons and neurointensivists during the acute care phases. Further, residents don't often get to see patients in an outpatient setting, and particularly may miss out on opportunities to follow these patients over a long period of time. So some of the problems faced bear further discussion. We can do the best job in the world with our surgical techniques and meticulous critical care, but if patients do not receive rehabilitation or other later phase services that they need to optimize their outcome, what we do may be of little consequence in the long run. It is therefore imperative for neurosurgeons to have an appreciation for these issues. The Bpse Paradigm considers that the healthcare system must serve as a lens by which we can refocus the patient's trajectory over time to optimize care and therefore outcomes. We know that these biological, psychological, social, and ecological influences impact on outcome. Examples of how this can be achieved include formation of treatment algorithms that highlight all aspects of care and don't necessarily focus on only the acute care aspects. Another example is the formation of interdisciplinary care teams inclusive of care coordination navigators. One challenge that is frequently seen is that these services are not compensated via traditional payer mechanisms, and therefore healthcare systems may not be willing or able to hire into such positions. I would argue that these people pay for themselves in larger ways by helping to avoid costly elements of care like unnecessary redundancies in care, reducing medication costs when therapies are no longer needed, or eliminating readmissions for clinical problems that could be handled before they rise to the level of hospital admission. Not to mention that having a patient navigator fulfills major patient and family satisfaction needs and can ultimately actually result in better long-term outcomes. One way to advocate for these positions is to consider TBI for what it often is, a chronic condition. While TBI certainly stems from an event, the consequences can be lifelong, even for less severe injuries. Our abilities to predict which patients will suffer from long-term sequelae and which will not are less than ideal, particularly in the early stages of assessment and treatment. One thing is clear, however, and that is that many patients will have lifelong symptomatology, and the TBI becomes transformed from an injury event to a chronic condition. It is interesting that stroke, which is also an event, is already commonly conceptualized as a chronic condition, perhaps in part because of the underlying factors that lead to stroke. However, TBI is no less a creature of underlying comorbidities and is no less chronic for those with deficits. The cost of chronic diseases in the United States is estimated to be in the trillions for direct annual healthcare costs. For TBI alone, the cost is also estimated to be in the trillions, with billions of dollars expended in direct medical care, and opportunity costs being much, much higher, due to loss of work productivity for those who succumb to their injuries and in both survivors and their families. Lost time to care for patients or provide additional help and services must also be taken into account. As mentioned, the National Academies of Sciences, Engineering, and Medicine recently convened a panel to write a report on the current status of care, education, research, cost, and other issues surrounding TBI in the United States. This report is available for free download on the National Academy's website. Additionally, the findings were synopsized in this JAMA editorial, and the members of the TBI forum that arose from this report and their respective organizations are shown. Stakeholder groups include various public and private sector organizations. Numerous governmental agencies, patient advocacy groups, private companies, and medical societies are involved. The initial recommendation was that the NIH convene a work group to develop more precise and practicable classification schema that take into account more of the many nuances of injury that impact on outcome. Examples of factors that impact outcome include genetic and epigenetic factors, medical, psychological, and behavioral comorbidities, mechanisms of injury and polytrauma, imaging characteristics, neurophysiological responses to injury, social and economic environments, and more. Further characterization of TBI as a chronic medical condition will aid care providers and payers in coordinating services across the continuum of care. The current model of payment for acute care services and perhaps some degree of rehabilitation does not adequately address many of the long-term care needs of many patients, and disparities in care are common. The medical profession has striven to provide evidentiary bases for care of TBI since ancient times. In the recent era, stemming from the early 1980s and the Traumatic Coma Data Bank, through the various guidelines efforts of the 1990s and 2000s, and many failed interventional trials over the past few decades, we have gleaned some degree of evidence, but the foundation for many decisions is still lacking. The third recommendation was for professional organizations and bodies to attempt to bring together the various clinical practice guidelines to aid all stakeholders in the determination of appropriate care. Expansion of educational efforts of the public and professional training in traumatic brain injury was also recommended. Private companies are now getting into the patient education space. I find this encouraging. The first time I ever heard the words traumatic brain injury uttered on television was in 2003, 6 years into my career as an attending treating this patient population. This was in large part due to military injuries becoming increasingly recognized in the post-9/11 military actions. While military TBI was a focus of attention throughout that decade, sports-related injury has largely supplanted this in terms of public attention. Even the personal injury attorneys have something to say in the public education space. While it isn't necessarily clear where they obtain their factoids for public consumption, this slide highlights the need for better epidemiological data. care systems that reinforce longer-term integrated TBI care were encouraged, with involvement of a variety of stakeholder organizations without quote-unquote reinventing the wheel. Encouragement of governmental agencies, EMR vendors, and various registry efforts to coordinate surveillance and epidemiological efforts is an integral part of delivering on all of the other goals. We are hampered in the development of a learning health system by a variety of factors. Proprietary electronic medical record systems which do not talk to national or local registries without a great deal of expense, information technology time, and redundant development of handshakes between databases is a significant obstacle. This applies to all clinical conditions, not just TBI. We are also limited in our ability to translate best clinical practices into economical value because of numerous historical factors. These include healthcare system reliance on administrative or billing data rather than clinical data, and business arrangements that preclude sharing of economic contribution margins for services provided to specific patient populations with the healthcare providers delivering the care. Also, despite our advanced technological communications and data analytics capabilities writ large, healthcare systems have not kept pace with these capabilities to translate information captured in the medical record into real-world data analysis or patient education opportunities. The idealized learning health system must address these issues to help patients and ultimately ensure its own long-term survival. Research must be expanded in order to answer key questions of prognostication, interventional effectiveness, and even cost analyses, amongst other topics. The actual cost of TBI care warrants a much higher level of investment than is currently being done. The identified 8 areas of interest include studies on epidemiology to better understand the true burden of TBI and inform prevention efforts. Economic studies are also needed. Near and dear to my heart, research on factors influencing prognosis and outcomes is third. Expansion of validated tools for measuring TBI risk factors, diagnosis, classification, monitoring, outcomes assessment, and prognostication are also imperative. Evidence-guided therapies for treating TBI and improving outcome deserve more investment as well. Finally, research on disparities in care and their influence on outcomes is emphasized, as are innovations in coordinated TBI care in various organizations and regions, and healthcare quality, economics, and implementation science research with specific focus on TBI. The final recommendation was to establish a TBI task force under the HHS that would develop a strategic approach to address those recommendations and to monitor progress on the national TBI agenda. The National Academies Forum represents a form of public-private coalition that can help advance a framework for action. This slide was developed to illustrate the journey of a patient through their TBI experience. While the types of TBI we encounter as neurosurgeons are more apparent, it is unfortunately all too frequent that patients suffering from milder forms do not acquire an accurate diagnosis. The classification piece is perhaps of most interest to us as neurosurgeons, and in particular, the use of data to prognosticate and help families and patients know what to expect in informed decision-making. We have notorious gaps in information in this regard, and bringing large data sets together to formulate appropriate prognostic information to inform care is not only a passion of mine, but is a needed focus, particularly for more severe forms of TBI. We owe society better methods of understanding to inform those difficult bedside care decisions which we have all personally experienced. We also stand to improve our acute care by delineating efficacious, cost-effective interventions and neuromonitoring techniques, as well as rehabilitative treatments. However, for those surviving these phases of care, there may still be a long road ahead, and some of the factors associated with long-term follow-up are the focus of my review today. For many, the journey is not continuous or smooth. There can be biological, psychological, sociological, and ecological factors that lead to missed or delayed diagnosis, difficulty accessing specialized care, and loss to care over time, particularly for those who experience chronic symptoms and need long-term services and supports, or those who become re-injured. In my 25 years as an attending neurosurgeon caring for many hundreds of these patients, I've observed overt and underdiagnosed problems emanating from the original injury. Here, I've classified the various sequelae of TBI into these domains and will address each one in succession. The first area we will address is neurological and musculoskeletal. Certainly, anything the brain does can be affected to various degrees. We are familiar with the obvious deficits, such as speech problems, paralysis, sensory loss, spasticity, and imbalance. Special senses can certainly also be affected, as well as bowel, bladder, and sexual function. Taking visual problems into account alone is one example of diagnostic complexity. It's obvious that the variety of effects that can occur may require specialty assessment. Many patients will benefit from neuro-ophthalmological evaluation and even visual rehab. Other special sense deficits should be treated similarly. The musculoskeletal sequelae of neurological deficits become obvious and require intensive rehabilitation strategies to prevent and treat. Unfortunately, epileptogenesis after TBI remains a huge problem, with potentially serious quality of life issues and even fatal consequences. About 80% of those suffering a late post-traumatic seizure will go on to have further seizures, and therefore should be treated at the onset of the first late post-TBI seizure. The cumulative incidence proportion of seizure at 1 year post-injury has been assessed at 18.5%, all too common. However, there are few data to predict which subsets of patients will develop seizures. The degree of post-traumatic amnesia is likely a surrogate of severity of parenchymal damage. Based upon best available evidence, the most recent guidelines addressing post-traumatic seizures still do not recommend prophylaxis beyond the 7th day post-injury unless late seizures develop. While this recommendation has been relatively widely adopted, the recommendation for phenytoin and not levetiracetam to prevent early post-traumatic seizures has not been widely adopted, and levetiracetam is commonly employed for this purpose in many centers. The true incidence of post-traumatic hydrocephalus is unknown, and the reported range in the literature is quite broad, from negligible to nearly 1 in 2. There have been some predictive factors identified, as shown here, but the increasingly common utilization of decompressive craniectomy also plays a role. At this point in time, the progressive stages of post-traumatic hydrocephalus, including clinical presentation and imaging, are fairly well characterized. But epidemiology and management strategies require better definition. Furthermore, mechanisms of prevention and optimal timing of various treatment strategies remain unanswered questions in terms of evidence and are left to expert or consensus opinion. Post-traumatic physical symptoms are common for all degrees of TBI severity, and I will highlight some of the most common. This includes post-traumatic headache, for which certain risk factors are delineated here. It is imperative for the astute clinician to differentiate headache type and instigating factors so that appropriate treatments can be deployed. It is also important to note that these typically decrease in frequency, duration, and severity over time. Constitutional symptoms can be some of the most debilitating, and if present, should prompt a thorough hormonal workup. Many of these can occur even without pituitary or hormonal dysfunction, and treatment is symptom-based. While dysautonomia can occur in the ICU, its effects can also be long-lasting. The first order of business is to eliminate triggers. Treatment may include the use of opiate analgesics, beta blockers, NSAIDs, anxiolytics, and even novel depression medications. Impact of injury on physical appearance should not be underestimated as a cause of psychological adjustment problems and subsequent problems reintegrating into activities. Multiple factors can influence the appearance of TBI patients, from cranial nerve palsies to direct craniofacial trauma to spasticity and paralysis to the masked faces look of the quote-unquote deer in the headlights. Post-DC changes can be bothersome, but many patients don't wish to intervene for these, particularly if they're doing well, such as this happy gentleman patient of mine who didn't mind his asymmetric appearance and temporalis atrophy at all. Obviously, cognitive sequelae account for a significant burden of functional impairment after TBI. This can take many forms, and patients may be affected to different degrees in different domains. Detailed neuropsychological assessment is invaluable in defining exactly what is impacted and how much, and can inform cognitive therapy and adaptive mechanisms. Anatomical and pathophysiological mechanisms of TBI result in memory deficits being very prominent. Memory aids should be employed as much as possible throughout the course of recovery and may be needed lifelong. Neuropsych assessments can also uncover mood problems post-TBI. Depression is extremely common post-TBI, with about half of people experiencing it within the first year and 2/3 within the first 7 years. Suicidality must be repeatedly assessed. Anxiety is also frequent and may take many forms. Adequate diagnosis must be made in order to inform proper treatments. One of the most commonly reported problems is emotional lability in a variety of forms, encompassing sadness, irritability, anger, and intense emotional reactions. These are some of the most difficult to handle for families. Also difficult is adapting to the quote-unquote new normal or the person that a loved one has now become who is different than who they were before. Many behavioral changes can emanate from a TBI, and the most common of which is impulsivity that can result in re-injury. Inability to tolerate high stimulation environments is very commonly reported and can be mitigated until it resolves by short duration exposures and rest between events and excursions. Particularly with bifrontal injury, motivational issues can come to the forefront, impeding rehabilitation and reintegration. Again, personality changes may occur that may be difficult for family and friends to address. When people withdraw from the patient because of these, it can set up further isolation and exacerbate other issues. Divorce is common, and patients may lose their social support network because of a lack of understanding of the impact of the injury on their personality and behavior. Those patients with outstanding social support networks tend to adapt and do much better in the long term. Communication problems can impact recovery and reintegration into the community as well. Other than the obvious speech deficits that can occur, a variety of other aspects of both verbal and nonverbal communication can impede understanding of and by the patient in social situations. Organic brain dysfunction can impede ability to read facial expressions and understand various other social cues. Abnormal speech patterns and lack of speech prosody can result in misunderstanding of this TBI survivor's intentions. Flat affect, lack of awareness of personal space, and tendencies towards swearing can all result in others avoiding the patient. Conversely, many survivors have no difficulties with communication at all and become frustrated by others speaking slowly and loudly because they assume that there is a problem. This can result in stigmatization of the TBI survivor as well. Finally, all of these aspects of recovery have different timings for improvement. There may ultimately be permanent impacts on the patient's environment and ability to reintegrate fully or partially into their communities. Some of these factors are listed here, and all should be taken into account when determining how to best care for patients over the long-term course of their recovery. Many of these issues factor into formal patient-reported outcomes assessments, and all should be addressed in follow-up appointments. Many solutions exist for even the toughest of TBI-related problems, however. Patients should be encouraged to maintain healthy routines incorporating well-balanced diets, good sleep hygiene with regular and predictable schedules, and some form of exercise if physically possible. Relaxation time and time for spiritual pursuits should also be encouraged for those who deem them important in their lives. Avoidance of substance use and abuse may be required even for more socially acceptable substances such as caffeine. Cognitive aids are plentiful, and depending upon the particular cognitive deficit, can help a patient move from one outcomes category to another on the GOS, not to mention function much better on a daily basis, or even allow return to school or work. Future interventions involving robotic exoskeleton utilization for immobility and spasticity may help existing and future patients. Brain-machine interface solutions to modulate spasticity and movement disorders, or to restore vision, hearing, sensation, movement, and even cognitive or mood disorders may also be of current and future benefit. I love this. Performing life-saving surgery is what we do and gives us meaning and purpose in our careers. It's why we get up in the middle of the night and put up with all manner of death by 1,000 cuts chores we must face on a daily basis. Rising to the technical challenge of a swollen brain in a rapidly evolving surgical setting and managing the myriad details of the neurocritical care course for days and weeks to follow is both challenging and rewarding. But I also love this. This is a very brave patient for whom I had the honor of caring for several years. He has had many highs and lows, many complications from his injury, and his family has been forever altered. His mother has become a tireless advocate for TBI survivors and a writer. His spirit of kindness and generosity has remained throughout his ordeal, but his life and that of his family has not been without suffering or hardship, despite their mantra that love wins. Ultimately, we need to do better with regard to helping people like Taylor throughout their entire journeys, and we need to learn from people like him and his family so that we can be more effective in our advocacy for their needs. Regardless of the problems faced, survivors and their families can often find peace, happiness, and satisfaction with life, and it is important to keep this in mind. I like this photo as it incorporates a variety of life factors that help us all find happiness. Family, friends, pets, nature, and most importantly, time for reflection and illumination. It is imperative that we try to help our patients with TBI achieve the best possible outcomes for their lives, not only by giving our best efforts at diagnosis and management, but by attending to the needs and desires of the entire person. Thank you very much for your time and attention this morning. I look forward to your questions, our learning sessions with the residents, and small group meetings with faculty throughout the morning. I again thank you for inviting me to share my thoughts today and to get to know more about your program.
Beautiful, beautiful talk, Dr. Timmons. Amazing. I saw a lot of stuff and I was getting a lot of text about some of the work that you're doing and how there's a tremendous overlap. Maybe I'm going to kick it off because I know Diogo was texting me about some potential points and questions related to the Department of Defense, and your work, of course, intimately relates to a lot of this stuff. I mean, I always think that what we're doing in the operating room sometimes, even as controlled as it is, with the surgeries that we're doing is nothing else but trauma to the brain, and we don't understand it. Even when we're taking a tumor, when we're taking a vascular lesion, you know, we are creating micro trauma. We just really have a very, very poor understanding in a lot of these things. And of course, the numbers that you show were amazing. So Diogo, you want to take it away? You want to kick it off? And I know Dr. Miller was also texting me about some questions that he had and stuff like that. Go ahead, Diogo, please.
Yes, sir. So Dr. Timmons, thank you again for the talk this morning. We learned a lot. TBI seems to be also a topic where potentially there's room for disruption. I remember there's a recent paper from Switzerland and University of Pittsburgh on neuromodulation on lumbosacral roots, and they were able to get a patient with spinal cord injury to walk again. And I was wondering if you think that some sort of an implant that is low profile, like for instance, the one we're testing, would have also an avenue for potentially changing the outcomes in patients with brain traumatic injury. And on a second question, I was also interested by the slide you had on epileptogenesis in patients that have BTI. In your opinion, what do you think is the main unmet need in that patient population? And thank you again.
Surely. On the first question, I think there's room for all manner of intervention to restore function. So I really believe that, you know, we can't do anything about the injury that occurred. We can intervene on the acute care side to try to make sure that we do the best possible surgery and that we, you know, provide the most meticulous neuroprotective care in the ICU by avoiding secondary insults and maintaining ICP, CPP, PbTO2, all those things that we do. And that really does impact outcome dramatically, actually. But patients are still going to be left with deficits. And I think that there's a lot of room for both spinal cord stimulation and brain machine interface type of interventions to get people back to some form of functional ability. With regard to epilepsy, I think the main thing that we don't understand, we don't know the epidemiology well. I think that we, are starting to have these large registries. The one that I showed you was a countrywide database of all patients in that country that had TBI. So I think, longitudinal registries for TBI patients are really important, and they will help us to understand not only the incidence, but also the timing of when these things happen. Certainly late seizures do occur fairly often. And I just, have a patient in the hospital recently that had status a year went into status a year post injury. And so if we can kind of get at what the incidence is, we can probably make better recommendations about treatment and preventive measures. I think there's a lot of really cool lab work going on too about epileptogenesis after trauma and other insults like subarachnoid hemorrhage, was just mentioned in the chat, and understanding what really starts the ball rolling on seizure generation will be really critical to stopping that from happening.
And Shelly, just to follow up, because I'm fascinated by this. One of the things that we know in the operating room is, so we invented with Dr. Tatum, and I don't know if he's here, he's one of it, and we invented the concept of oncoepilepsy. So we go into the operating room, patients are wide awake, they're you and I talking. We put this grid, circular grid that we invented as we're gonna collect data before we take out the lesion, and they're having spikes. They're having seizures and they don't even know it.
Right.
And I wonder if in our trauma patients, and those seizures, by the way, and you do the surgery, you look at their quality of life, how they feel after, they were having an issue in their brain, but they don't even realize. I wonder if the same thing, and this is why the device, the other patent that we have, what we're doing with Jennifer, and I asked Diogo to make sure that we connect with you, is because what about a day when we envision, when you go back and you do your cranioplasty, you have to put a piece of Duragen or something. This is what we did. We invented a device that is low, a film that then allow us to wirelessly collect data and find out what's going on with those patients. And I envision a future in which we are going to be better able to treat those patients. I was fascinated by that concept. And your numbers, of course, that are staggering in the world for a tremendous unmet need.
Yeah, that's very cool. I mean, I think that we definitely see that patients have pleds sometimes.
Yes.
They have no idea. And, we know that TBI patients will tend to have these like stuttering courses, like they'll do well for a while and then they'll kind of plateau, or they'll go backwards and then they get better. And, it could be that they're experiencing sort of subclinical seizure activity or pleds or other abnormal electrical activity in the brain. Spreading depolarizations we know are common acutely. And so anything that we have, like I'm a big advocate of using all the tools that we have to measure, what's going on. And I think that's a really neat invention that maybe at some point we can deploy in these patients.
Beautiful. I know Dr. Miller because he was texting me. Dr. Miller, go ahead. Because he's thinking subarachnoid hemorrhage, of course. Go ahead, Dr. Miller.
Yes, yeah. So I'm an interventional neuroradiologist and part of the neurovascular team here. Again, fantastic talk. Over my career, I've seen a lot of TBI, and one of the things that was really striking about your talk was that I think that many of the patients that we see who have subarachnoid hemorrhage have many of the post event problems that your TBI patients have. So many of the things: memory, concentration, mood changes, etc. And I wonder a lot whether, obviously, there's going to be some common pathways here. And I think, again, maybe Dr. Q and Diego and Dr. Tatum's monitoring thing would be an interesting way to go about looking at this. Obviously, we do so much more endovascularly now, but in maybe some of our patients who have craniotomies for a hematoma associated with this, or patients who get open vascular repair, I think it would be really interesting to monitor some of these patients and see. Do you see things? Do you see common pathways? Are there things that have you've seen along your way that may marry the two things? Because there's some kind of the symptomatology being so similar that there must be some common events and pathways.
Yeah, I definitely think so. Whether it's just from the presence of blood in the subarachnoid space, or if it's secondary injury from subclinical or overt vasospasm, not getting enough oxygen to the areas that have an increased oxygen demand that have been damaged either from trauma or from an intracerebral hematoma. I think there are definitely parallels with the subarachnoid hemorrhage patient population. They certainly, many of them do act very similar to the TBI patients, but I think, whether that's from the actual hemorrhage or whether it's from some of this things that get set up in terms of secondary injury or both, we need a clearer understanding of that.
Yeah, that's actually quite interesting what you say. And one of the things we could look at, because we have a wonderful multimodality setup in our ICU, courtesy of Dr. Freeman and
Yes.
all his work, and we could use NIRS patches and other things to sort of see some of the oxygenation issues if they're common in post things. I mean, there's lots of issues. That'd be great. Well, thank you for the thoughts. Hopefully, maybe we can talk about that later at some time.
Perfect.
Wonderful. Thank you. I know that we're taking a little bit of extra time, Shelly, but I hope you don't mind. I see Mara right
Ready to
here.
get this done?
And then I'm going to try to mute Dr. Notmeyer. He's already getting ready in the operating room. Yes, we're ready, Dr. Notmeyer. We're ready. But let's see, Mara, you want to go ahead and ask your question, and then I go to Lina. Let's see. Go ahead, Mara, please.
Thank you very much for this talk. I find it very interesting because my brother and his wife, they are both residents in pulmonary and critical care in Emory University. They just got a case in which a patient with 3 weeks of fever and a productive cough had a negative tuberculosis sample of sputum, and the CT scan showed massive right ventricular destruction and a left intracavitary lesion of the left ventricle. And after 3 days in the intensive care unit for intubation due to respiratory failure, there were 4 samples positive for tuberculosis, and the patient presented with right gaze deviation and left-sided weakness. A transesophageal echogram showed a left intraventricular mass, and so the 3 differential diagnoses that they found were either a intraventricular thrombus formed in the absence of structural abnormalities, or a thrombus formed in the cava vein, in the pulmonary veins that migrate to the left atrium and then the left ventricle, or a intracardiac tuberculoma that leads to the emboli in the right anterior cerebral artery.
And
So
Mara,
where
can I ask you to just point the question for the traumatic brain injury portion, if you can help us understand what is the question and what is the question for Dr. Timmons?
That if this patient had the emboli, if it were in the right anterior cerebral artery, the presentation was right side gaze deviation and left side weakness.
Yes, and the question being, I just want to be more pointed in regards to the question. What is the question for Dr. Timmons? Because she's talking about traumatic brain injury. Was there a specific question about this for Dr. Timmons? As you're thinking about the question, maybe you put it in the chat. We're going to pivot. I'm going to go back to Lina. Lina, you want to go ahead and ask your question?
Sure. Thank you so much, Dr. Timmons, for your wonderful talk. I do have one question about just like the future of monitoring for TBI patients. So I just wanted to see like what you thought about, using handheld dynamometry to monitor the recovery of patients with TBI. I know they used it for children, but I'm not really sure if they used it for adults. And then the other thing I wanted to ask you is, what do you think are the solutions to make it more accessible for these patients to be more compliant with their follow-up after the monitoring, either if it's apps or things for these patients to not just get lost to follow up and all of that?
In terms of the neuromonitoring, I think, we can't have too much data, right? I mean, I think there are so many things that are happening in the ICU and then even at home that the more technology that we develop to understand what's going on with, blood flow and autoregulation and everything, even ultrasound for monitoring structural lesions, I think is one of the things that is potentially up and coming. So I think, the more tools we have, the better. I don't know that technique has been really utilized heavily in adults yet. in terms of the follow-up, one of the things that has worked well in settings in my practice experience has been to have people whose basically their everyday function is to help these patients navigate through the medical system. If anybody's been a patient lately, you know that it's difficult enough when you have all your faculties about you, and then when you have problems with memory and concentration, attention, and all these other kinds of cognitive impacts, and maybe don't have such a great social structure around you, you really have to have somebody to hold your hand through the process. And so, having a nurse navigator or having a patient advocate or we have had in the past, in my practice, I had a state funded TBI coordinator who would help people with things. And so, the more that we can support people through various mechanisms to have a point of contact, somebody that they get to know, preferably they get to know them when they're in the hospital and they have that longitudinal contact. I think those are things that work well with this patient population.
Beautiful. And I see Dr. Vargas from Bucaramanga, from Colombia. Dr. Vargas, and by the way, we had at one point over 80 participants from 10 different countries. I also see Jose Luis Alves from Portugal, who's interested in traumatic brain injury. So he's been listening to you, Shelly. So go, Gabriel, take it away, please. One last question. I know that we're running a little bit behind, but it's a fascinating topic.
Yes, TBI is one of the most difficult situations that we have on neurosurgery. And thank you very much for that focus on chronic disease, because this is the reality and the difficulty that we have in order to get those patients functional and social activities and really go to the same kind of situation. And we have these kind of situations in different diseases as brain tumors and vascular situations. Just one question. What is the role right now of the compressive craniectomy? Because when we see the patient at the beginning, always we think, okay, the first opportunity, as in many situations, is the best opportunity for the patient. So in your thinking, there is a role for more decompressive craniectomies, because ICU people push us to do that, and many times we have a doubt if this can be the patient or not. What are you thinking right now about that?
I mean, I think that I'm pretty aggressive about my approach with decompressive crania. I think unless you have some really severe, poor prognosticators like, brainstem dysfunction or lack of, pupillary reactivity for a long period of time, older patients, et cetera, that it really does play a good role in mitigating not only the ICP and CPP blood flow problems that we struggle with when the cranium is intact, but it also allows for basically less therapeutic side effects, right? Because so much of what we do in the ICU, if we're hitting everybody with mannitol and hypertonic saline and sedation and paralytics and even other interventions, those have their own side effects, right? So what it does do is it allows the therapeutic intensity level to come way down. It allows for us to kind of let the patient wake up sooner and see how they're doing. So I'm a big believer in the surgery. I think we've got data that shows that it does improve outcome when used carefully in patient selection, and it can even be used in low and middle income countries to help survival. And I think that that's one of the things that needs to be studied more. I mean, I think we just have to look at this as a technique that has advantages and certainly some disadvantages. I mean, it's like any other operation, right? It has complications. There are things you have to deal with down the road, but we certainly do a lot of pretty complicated operations for other conditions that also, that we know that we're going to be dealing with things. So I think that it does play a very key role in preventing secondary injury, and we probably ought to be considering it more often and early, especially in those patients who are very difficult to manage with their ICP.
Beautiful. Shelly, thank you. Dr. Timmons, wonderful. Thank you, Gabriel. And thanks everybody Shelly, we took a little bit longer time, but I know that you have some minutes. Thank you for dedicating your morning. I
My
know
pleasure.
that you're coming up, meeting with Dr. Freeman, who was asking, he's a neurocritical care, lead, the director of our neurocritical care, who's he's waiting for you, and the other connection. And then you're going to be meeting with the residents and the fellows. They need to meet with you. They need to hear from you. They have questions from you, all the way from career advice to the study, the disease that you're studying. So thank you for the residents and fellows for doing that. And then I'll come back with you at 9:15 just to wrap it up for a few minutes. I thank you immensely, and Andres, did you send Dr. Timmons her plaque already, or you're in the process?
We ordered it already, so it should come to your desk soon.
Very good. Well, thank you very much. It's been a pleasure being here with you all this morning. I look forward to my further conversations.
Beautiful. Well, connect. You have the other link that Andres sent you already early in the morning, and they're waiting for you right there. And then I'll see you in a little bit. And thanks,
Okay,
residents and fellows, for meeting with you. Thanks, everybody. Have a great week.
Take care,
Thank
everyone.
you.
Adiós.
Thanks.
Buena semana.
Adiós. Gracias, Gabriel.